Good evening, everybody. I just need to get a few things loaded, and we've got about 5 minutes before we get started. So talk amongst yourselves if you like, or just hang out. Bear with me while I take care of some of the administrative stuff.
Hey, can you guys hear me?
Yeah, I can hear you. Can you hear me?
Yes.
Yay!
Can you guys hear me?
Yes.
Hi guys, are y'all ready to get started? I have that it's just a little after 6. Give me a green check if you can hear me. Great. Okay, it looks like the majority of you are in. Sarah, you were able to get on your mobile phone. That's awesome. I'm not sure what features you have available to you, so it looks like you could be texting us. So we'll just see how that goes. Wonderful. Okay, sorry about the delay in getting started. For some reason, when I load the PowerPoints, it always skips the first slide when I have to load a second one. So there's the first slide for the presentation tonight that Brittany, Taylor, and Danielle are going to do for us. So we will just have to come back to that afterwards. Before we get into the lecture, though, on ortho, just a couple of quick announcements. One, please, 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 I told the group yesterday this, watch the videos, the clinic demonstrations prior to coming to clinic. I didn't put the videos up there this year to be all tech savvy and all that good stuff, but I did it so that way we actually save clinic time, okay? So that way, when you come into your clinic session, you've already seen a demonstration. You can play with the materials. You can do the best that you can do on your own. And then I'm there to answer questions, because with us having patients and that sort of thing, sometimes it's just a little too chaotic for me to commit. And I don't want to hold you guys up as well when it comes to getting things done. So that is the purpose. It is required that you watch those videos. I will not be doing live clinic demonstrations. You've had your first quiz. So any comment or feedback? I believe one of the questions may need to be adjusted. The one that has like the different functioning levels, I think. When I look at the item analysis, there seemed to be a little bit of an issue about whether it could calculate it or not. But did you guys have any questions about the quiz? Any comments, feedback for me? I'm going to turn off my mic so y'all can talk to me.
I took mine yesterday at around 5 when I got home because that is what worked out better for me, and I thought it worked out quite nicely. I think there's a good amount of time to be able to get it done.
Thank you, Brittany. I appreciate that feedback. Yeah, that quiz last year was one that I actually had to redo because it was not a very student-friendly quiz last year, and I have to say I actually lectured on all of that pedo stuff in one setting. So I'm hoping that it was a little more, a little friendlier this year. So good. I'm going to turn off my mic and see if anybody else wants to add anything. But I didn't get any emails. I didn't get any phone calls that there was a problem with it. So feedback. How was the Wednesday night into Thursday? Did that work well for you guys?
I just took it today because I had my rotation yesterday. I was just so tired yesterday, so I just had a lot more time today to take it.
Thanks, Taylor. So it sounds like it seemed to work okay being Wednesday night into Thursday. Everybody had ample time with their crazy schedules. And you're tired. Yes, working all day long is very, very tiring. Before I turn off, get going though, I was reading the text chats. Taylor said that her rotation was fun, and that's great. I think you guys, it's just such a wonderful opportunity that everyone has to participate. It makes, I know it's hard to embrace everything right now, but I think it really makes a huge difference. It's one of those things that sets us apart from the other programs that aren't accredited. And it does let you see if there's any other aspects of dentistry that you would like to work in. So, good. I believe Mrs. Thomas will be doing her first online meeting with you guys next week after our class. So you'll just have to probably log on to her Collaborate session. But if I don't have any questions about anything, we're going to go ahead and get started on our ortho presentation. Any questions? You can just raise your hand for me if you do. Okay, I don't see any. All right, well, we're going to go ahead and we're going to start talking about ortho. Orthodontics, it's in its most primitive definition, is just moving of teeth, okay? All right, so who can do it? Who's a part of the orthodontic team? General dentist can do orthodontics, okay? It's not prohibited. However, if that's all they do, then they do need to be that specialty. Okay, I see Julie is with Andrea again. Thanks for letting me know. The hygienist is a part of the ortho team. You're probably starting to see, as you've gone through the lab now, that there's a lot of appliances in there, and it's going to be really hard for the patient to keep their oral cavity clean. So we definitely need to have the preventive person on board. Obviously, the orthodontist and assistant. In our area, in our state, orthodontists are primarily the doctors who do the moving of teeth. again, they are a specialty. They have their dental degree, and then they go to at least 2 years beyond in order to become an orthodontist. You have an assistant, and it can be an assistant at your level, but there's also a certified orthodontic assistant. So if this is something that you really like doing when you go on your rotations, that's something for you to consider, okay? It's an additional certification that you can get beyond your CDA, and the office manager is a big part of it. As we talked about with fixed prosthodontics and removable, if you recall, we talked about the office manager playing a part in treatment planning and explaining that payment plans are more frequently used in ortho, so they have a little more active role. We have the laboratory technician. The lab tech, they can fabricate appliances. So after we have completed the moving of the teeth, the actual active orthodontic treatment, many times we'll have a retainer that is fabricated by the lab tech. Sometimes we have to use different appliances, such as Herbst appliances and things like that. Okay, the patient is obviously always a part of the team. And with the patient, we have two different things to note. We can use a philosophy of ortho that is guided development. So starting about 8 years old, when the teeth are coming in, we may want to do interceptive orthodontics where we're guiding everything, okay? Sometimes patients wear the braces for less amount of time when we can guide things in and help with that development. And then there's the philosophy that we really don't need to do anything until we have a fully erupted permanent dentition. Both are legitimate philosophies. You may find practitioners that believe in both philosophies and use them on patients differently, okay? It just depends on the positioning of the teeth and that sort of thing. The ortho office is typically an open bay environment like we saw in a lot of the pediatric offices, and then they do use the Palmer notation system exclusively. So real important that before you go on your ortho rotation that you review that notation system, okay? All right, so as we go into this, we're going to do a review of our occlusion because you need to have a really good understanding of occlusion when you're in your ortho rotation, okay? So remember, Class 1 occlusion is our neutro occlusion. This is where the mesial buccal cusp of the maxillary first molar occludes with the mesial buccal groove of the mandibular first molar. Okay, that's just how the molars come together. In Class 1 occlusion, though, you may see anterior teeth or other teeth malpositioned. Okay, it doesn't mean that it's perfect, perfect dentition. Not sure that that exists, to be honest with you. Okay, my little picture here is covering here, but now we're going into Class 2 occlusion, and this is what we consider disto occlusion. So it's where that mesial buccal cusp of the maxillary first molar is mesial to the mesial buccal groove of the mandibular first molar. Okay, so it's almost like the maxillary or the maxilla moves forward. Division 1 is where the maxillary anteriors protrude facially with that real deep overbite, and you can see the picture down here. And then we have Class 2 Division 2, and this is where you start to kind of get that flaring. And this picture right over here, let me use my tools, I think shows it probably the most dramatically. Oops. Okay, and bear with me here, but right here, do you see that flaring of the central incisors, okay? The flaring labally of the laterals, and you've got a real deep overbite, okay? And it can be and or. It doesn't have to be both of them. Everybody give me a green check if you're okay on Class 1 and Class 2 occlusion. Excellent. Going into Class 3 occlusion, this is what we call mesial occlusion. The mesial buccal cusp of the maxillary first molar is now distal to the mesial buccal groove of the mandibular first molar. And a lot of times what you'll see is that the anterior teeth become in crossbite, and that's where the maxillary teeth are supposed to sit over, but now it's like an underbite or a crossbite there, okay? And I just always remember that when I'm in neutral occlusion, it's right where it's supposed to be. And then I move forward to Class 2, and then I move back to Class 3. And for some reason, that just sticks with me in my head forever, okay? It's real easy to start looking at everything else that's going on, but occlusion is only dealing with the teeth. And even though we show you some profiles here, don't let those profiles fool you, because some people can have the different profiles, but their actual occlusion is not what the profile is. So you always want to make sure that the doctors are looking at the teeth, and usually they are. Overbite and overjet. Remember, overbite is how far over the mandibular teeth are covered by the maxillary teeth. I don't know a better way to say it. And then overjet is what we all reference as being buck teeth, okay? And I think that, you know, in our lay time before you've actually come to dental school, we always think that buck teeth is overbite, but that's really not the case. Buck teeth is really looking at overjet, okay? How far do they protrude over? And that's measured in millimeters, where overbite is measured in slight, moderate, and severe, okay? And remember, in order to get each of those, we divide the tooth into thirds. So the incisal third would be slight overbite, the middle third is going to be moderate overbite, and the cervical third being covered is going to be severe. Does that make sense to everybody? Give me a green check if that makes sense. Okay, good. I see your green checks coming in. Okay, good. I've got about the majority of you, so we'll go ahead and move on. Okay, so other factors that we look at is open bite. This is where the teeth do not occlude. Crossbite is where the mandibular teeth may be buccal to the maxillary teeth, or we could say the maxillary teeth are lingual to the mandibular teeth. It looks like Danielle, are you trying to talk, Danielle? If so, just raise your hand for me and I'll turn off my mic. No? Okie doke. Alrighty. And crowding, I think, is pretty self-explanatory. So what are some of the factors that affect occlusion? One is going to be developmental issues. So are they naturally missing teeth? Are there any malformed teeth? Do we have supernumerary teeth, or are there teeth that are impacted? Okay. Thank you, Danielle, for clarifying. Is it genetics? Do they have small teeth with a large jaw? Okay. Or maybe they have large teeth with a small jaw. Are there injuries such as fetal molding or trauma, things that actually happen during the birthing process? or has the child had some sort of injury that has caused a problem in development? Have they lost their teeth early? And what would be some of the things that would cause them premature loss? I'm going to turn off my mic. So maybe, let's see, Brittany, you don't, I know you always talk, sweetie. Let's see, it looks like Sarah has a let's go with Sarah Pfeiffer. You're next on my list. So tell me, what would be some causes of premature loss of the baby teeth? Okay, I'm not hearing Sarah, and it doesn't look like her mic was turned on. So I'm going to go down to Andrea and Julie. You guys can tag team this. What would be some causes of premature loss of the teeth?
We're talking about primary teeth, right? The premature loss of primary teeth.
Did I hear you correctly that you're trying to find the causes of premature tooth loss?
Can you hear us?
We can hear you. It was just, it's a kind of a little garbled. It was hard to hear what you were saying. It sounded like you were looking up the causes of premature tooth loss.
Primary tooth loss, right? Of the primary teeth?
Primary or permanent, it doesn't matter.
So I was at the Pete's office this week, and a boy, he was about 2 years old, he was almost 2, and he had really bad baby bottle tooth decay. So they are setting him up for oral surgery so that he can get all of those teeth extracted, and he won't have teeth until his permanent come in a few years, in a while. Also, if there's a lot of decay in the teeth, they have to pull them, or fractures or anything that makes the teeth fall out.
Good, Julie. Can you maybe talk a little bit more about the implications that those extractions are going to have on the development of the permanent teeth?
The patients are probably going to have a lot more crowding and spacing problems, since they're not going to have those teeth in place to keep the space maintained until their permanent teeth come in.
Good. And do you think that there might be a delay in the eruption of the permanent teeth now?
Yes, I think so.
Good job, guys. That's exactly right. Okay, so other things that they look at that's going to affect the occlusion is going to be any habits, such as tongue thrusting, any finger or thumb sucking, bruxism, mouth breathing. Okay, all of those things will affect the occlusion. All right, so what are some of the benefits of orthodontics? One, the patient will have improved confidence. They'll be more satisfied with their smile, and that increases our confidence. The patient may have improved digestion. Think about if the patient had an open bite and they weren't adequately able to crunch up food, okay? And so they had to have a softer diet. So it's going to improve chewing and swallowing. We will definitely have improved speech. Have any of you tried making a sound without your teeth touching together, without closing your mouth? So just try to say the word teeth. Say the word teeth without your tongue touching your teeth, and see how you say it. See, y'all can do this because you don't have a mic right now where all of us can hear you. But just try different words and see how it is. You have decreased temporomandibular disorders. Okay, and obviously overall improved health, because if the teeth are lined up nicely, it's much easier to keep them clean than if they're crowded and that sort of thing. So we have fixed appliances, removable appliances, and then we actually have orthodontic surgery. So let's see here. So some of our fixed appliances would be things like the bands and brackets, Herbst appliances, palatal expanders. Then we have removable appliances, and removable appliances would be things like retainers. And then we can move into orthodontic surgery, and that's sometimes like breaking the mandible, resetting it. Sometimes it might be shortening the mandible, okay? So cutting it, taking a section of it out, and then resectioning it. So steps in ortho, obviously we always want to review the patient's health history, their dental history. They'll do a physical growth evaluation, and this is where they'll take the pan and the cephalometric x-ray. Okay? Tell me what the cephalometric x-ray is used for. Anybody can pipe in.
I know that it's an image of the whole head and all the surrounding areas there, but I don't know, all the intricate details of it.
Okay, so good. Taylor says, is it a profile view? It is somewhat of a profile, but what the Ceph does is they can trace the growth pattern on it to see where they expect the growth to be and that sort of thing. Okay, Sarah says to see the jaws. The pan is used primarily for that, but the Ceph is more to look at the growth profile and to anticipate that sort of thing. So we look at behavioral evaluation. What are the patient's oral hygiene habits? I don't think any of you are scheduled to be with the orthodontist at Virginia Dental Anesthesia Associates, but she's very picky in who she picks to be her patients because she knows that if they don't have good oral hygiene, you can have beautiful teeth that are nice and straight, but they don't do you any good if they're ate up with decay. And so she looks at maturity of the patient and that sort of thing. And then they will do a clinical exam. And this is where they do a frontal view as well as a profile, so a side profile. And that's where they take lots of pictures. Then they'll do a dental and periodontal assessment because, again, we're going to be affecting the bone. And if the patient is not healthy periodontally, we probably don't want to do anything that's going to cause the breakdown of bone. And then we have jaw and occlusal function that we look at. We're going to take some diagnostic records, and this is where we get our photographs, a pano, a Ceph, and we take models. Remember that models can be taken now with either alginate impressions. You can take impressions and pour them up in stone, or we can do the digital models and see how everything comes together. Brittany, do you want to share anything about the digital impressions that you saw and what your thoughts were on that?
I don't think that was me. I don't think that I've seen the digital impressions.
Yeah, honey, you did. You saw it for crown and bridge. So with the digital impressions, what they do is they use a little bit of this powdery stuff, and then they just take pictures of the teeth, and then a computer puts everything together. So that way they can see how the teeth articulate and that sort of thing. I think Brittany's trying to talk. I'm going to be quiet.
I'll take my mic off. But yeah, you just jogged my memory. I do recall that now. When they take the powder and they go ahead and they just put a little bit of powder on the teeth, and then they take this tiny little camera, intraoral camera, really lightweight and stuff, and they just take pictures all around the tooth and all around the areas that they want to get, and then it just like a digital x-ray kind of just pops up right where you need it to be on the computer screen, and you can manipulate it from there. It's pretty neat.
Thanks, Brittany. Yeah, and actually the digital impressions are what is used most commonly with the Invisalign, which is orthodontic treatment using clear trays. I think Sarah has that. Sarah, when you had your Invisalign, did they use digital impressions on you or traditional?
They use the traditional ones, but they just got the digital machine, so they just started using it on all the other patients.
Bummer, huh? But
anyway,
so there's lots of different ways to get models out there now. But again, why it was so important that you learn how to pour up study models, because they need to be accurate and they also need to be pretty and presentable because they are used to present it to the patient and their parents or caregivers. The next step is to do the treatment or case presentation, and this is where the orthodontist talks about and shows the parent, you know, where are their problems, how do they plan to fix it, how much is it going to cost, how long is it going to take. Okay. The next step, once the patients accept treatment, is going to be to place the separators. And separators, your book talks about there being metal separators. Most commonly what I've seen are the elastics used, or plastic, little rubber band type materials used to serve as separators. The easiest way is to floss them down into the contact area. The patient wears them for about a week until they fall out. And then they come back for the next appointment where they place the bands and brackets and wires. Power products such as ligature ties and power chains may be used as well. And then the patient returns every 4 to 6 weeks for adjustments. The average ortho case is about 2 years. From then on out, patients will wear retainers. They typically wear retainers. It starts off wearing them 24 hours a day, then it breaks it down to maybe, you know, just at night while they're sleeping, that sort of thing. Most of the time it is recommended for patients who've been in ortho that they wear retainers for the rest of their life. There is that chance that there may be some changes where it goes back, you know, the body wants to go back to how it was originally. So what are you going to need? So when you do your tray setup, you're going to need your basic exam pack, mirror, explorer. You're going to need your bands and brackets. You're going to want to use chapstick, and a wax-based chapstick works much better in ortho, okay? You're going to prophy and the entire mouth using pumice. I have on here a glass slab because some of the traditional cements require that, but the newer ones do not. You're going to need a spatula, your band pusher and seater, a scaler. They call it an orthodontic scaler. It's really no different than a hygiene scaler, but that's to remove any of the cement that sets on the teeth. That really should be done by the dentist, but I know it's delegated many times to the assistant. You want to have your band remover, O-rings. This is what actually holds the wire into the bracket. You're going to need to have contouring pliers, which fit those bands around the tooth, bracket placement tweezers, arch wires, Weingart pliers, bird beak pliers, torquing pliers, distal end cutters, hemostats, a ligature director, and then ligature cutters. So this is just a setup from your book that you can see everything on there, and this would be for the placement of bands and brackets. And then here's an additional tray with things that you're going to need, okay, for when the wire gets changed each month or so. Okay, don't know why it's not progressing. There we go. These are some different appliances that you may see here, okay. This up here, let me go ahead and circle it. This is your Herbst appliance. It goes from the maxillary to the mandibular, and this is if we need to make movement to the jaw without doing any orthognathic surgery, okay? Maybe we need to pull the mandible back or we need to push it forward. That's where they use the Herbst appliance. You have the palatal expander right here. Patients will wear this many times while they're in active ortho. It's not worn for the entire 2 years. It's just until they can get the palate to the place that it needs to be. And you can see in this area right here, this small area, there's a little key that fits up in there. Okay, and every day the patient will stick that key in there and turn half of a turn, okay, and then it will slowly expand that palate. Headgear is sometimes worn, and you can see whether it be different types, Facebook or traction, and you can see it either connects cervically or does what we call a high pull, and this is where the patients wear it across the top of their head. Typically, headgear is worn at night while the patient is sleeping, because I'm sure most of you have seen movies where poor kids are made fun of wearing headgear to school and that sort of thing. And those of us who are a little bit older actually remember seeing poor kids come to school with headgear. Okay, oral hygiene is a very important piece of ortho. You have diet and nutrition that you're going to be educating the patient on. So they want to stay away from high sugar content, anything sticky, hard, anything that has husks, and definitely stay away from gum. The brackets will come off, and so if the brackets aren't connected to the tooth, even though the wire is there, you're not going to get that active movement. Okay, so we want to make sure that everything stays on. And then we want to give oral hygiene instructions every time they come in. Evaluate, do they have a lot of plaque? I've got some pictures here. Now, I've never had ortho, but I'm going to be quite honest with you. If I ever had that much material in my mouth, I probably wouldn't floss my teeth. If we were completely honest with one another, we don't floss our teeth as much as we should when we don't have challenges. So now you put some challenges on a teenager or a preteen, and to be honest with you, flossing is not really realistic, even though it is so important. So we have some things here. I highly recommend any patients with ortho to get a water pick. It's a nice way to keep everything clean. Electric toothbrushes, and then you have here that little Sonicare flosser. Remember I talked to you guys about that last year, how it kind of squirts, that it uses like an air type force. But even though I don't think it's the best thing in the world, it's definitely something that an ortho patient needs to have because they need more help with all of those appliances. So oral hygiene is super, super important. I have seen orthodontists who will take, they'll take it off. Patients' gum tissue just gets too inflamed, and they have too severe case of gingivitis, and they will stop ortho treatment until the patient can actually take care of everything. So, and you know, many times that's a huge eye-opener for the parent when the orthodontist says we're stopping treatment because they're not caring for them. Okay. I think that may cover, let me scroll down a little bit because I'm thinking it's not like me to end that abruptly, but let's see. We'll come back to all of these and let the girls talk to us about them. Yeah, so I think that must be all for ortho. Are there any questions about ortho? So through reading the book and my presentation, we should hit the highlights. Should give you a good idea. Oops, I don't need to go back that far. Sorry, I'm trying to talk and I'm just kind of clicking. Okay, so Taylor says she doesn't have any questions. Great. Okay, there is a nice little article for you to read. Oh, I'm telling you, I can't do two things at one time, guys. Okay, there we are. All right. Any other questions? I don't see any hands raised. Nope. Okay, so should I assume that Brittany is going to be the one doing the presentation since I see her name at the bottom? Okay, you each have sections. All right, wonderful. Well, what I'm going to do is I am going to give you guys moderator status. So that would be Danielle. So that means you're in control of everything. And Brittany is going to have that status. Okay. And then Taylor. Okay, my sweet girls, I am going to go ahead and turn off my microphone and let y'all take over from here. To change your slides, you should see something up that in the top right corner of your page that allows you to advance to the next slide. It says Page Explorer, and you just click that white arrow to the next slide. Give me a green check if you see that okay. Okay. All right, it looked like only 2 of you saw that. Was there someone who missed it? Okay, everybody's got it. All right, I'm going to turn off my mic, and it's all you guys. I'll turn off my video camera, too, if y'all want to turn yours on, so that way the girls, the rest of the class can see you.
Can you guys hear me?
Yes.
All right, sorry it's so dark in my house right now, but, you know, I do have my video on. All right, so we did infection control, and my section is principles, modes, and immunity. The principles of disease transmission is virulence, and virulence is the strength of an organism in its ability to produce disease. And the other thing is number of microorganisms, which is a high enough number of microorganisms must be present to overwhelm the body's defenses. Susceptible host is another one, and a susceptible host is a person unable to resist infection by a particular pathogen. And portal of entry is the last one, and the portal of entry is how the pathogen enters the body. All right, modes of disease transmission, as we all know, there are several of them, and the first one being direct, and that is direct contact with the patient's blood or saliva. Indirect, which is a contaminated instrument or surface. Airborne, which is the mucosal surfaces of the eyes, the nose, or the mouth. Aerosol, and there's different kinds of aerosols. There is a mist. Well, the aerosol is the mist, and that's from a high-speed handpiece or the ultrasonic scaler. Then there's the spray, and those are larger droplets, and those are high-speed handpiece as well, ultrasonic, air-water syringe. Spatter is the largest droplet, and that is from the high-speed handpiece, ultrasonic, air-water syringe. And to put it out there, sprays and spatter, they travel further than a mist does. They can reach the wrist, the forearms, the wrist, the forearm, the upper arms, the chest, and even the collar area. The next one is parenteral, and that is through the skin, such as cuts, punctures, bites. And then bloodborne, direct or indirect contact with blood or other body fluids such as saliva. And on to a few more. There is also food and water, and that is contaminated food and water, and that can produce botulism, staph, and strep. And then fecal-oral, improper hand-washing technique, or no hand-washing at all after using the restroom and then handle food and stuff like that. Definitely not very sanitary conditions at all, and that is going to produce some very poor results within yourself. There is immunity, and immunity allows the body to resist disease, and it prevents foreign bodies from causing an infection. And we have inherited immunity. Inherited immunity is present at birth. Acquired immunity is developed during a lifetime and can occur naturally or artificially. And naturally acquired immunity is you contract a disease and you recover through the formation of the antibodies. Your body makes it better by itself. And artificially acquired immunity is antibodies are introduced to the body via immunization. So we go to the doctors, we get the shot for chickenpox, and that's going to immunize us against the chickenpox. And then it can be further broken down. Naturally acquired, there's natural active. And natural active, you contract the disease and produce the antibodies. And natural passive is you receive antibodies via the placenta or breast milk. For artificially acquired, there's artificial active, and that is vaccination to produce the antibodies. And then there's artificial passive, which is an antiserum with antibodies from another host is introduced to the body. And then I have some questions for you guys, but before I get into these questions, I wanted to ask if anybody had anything they wanted me to go over again, or any questions for me at all. All right, I think I'm going to go with that nobody has any questions, so I'm going to go ahead and get into some questions for you guys. All right. Who is considered a susceptible host? Does anybody have any ideas as to who a susceptible host might be, or who is considered one? I see Sarah Pfeiffer saying sick people, kids, old people. Absolutely. Essentially, what the way to put it is it's a poor health, being chronically fatigued and under extreme stress, or a weakened immune system. So sick people are absolutely could have a weakened immune system, poor health, kids, older people, and then also, would we be considered a susceptible host as students and going through school and everything like we are? And yes, Ms. Mesmer just said people on corticosteroids, absolutely. And yes, Heather, we are considered a susceptible host because we are under a whole lot of stress. So our, immune system is not at full force right now because we're under some stress trying to get through school and all that. All right, so my next question is, what mode of transmission is a needle stick? Does anybody know? I have Ms. Mesmer saying indirect and Heather saying direct. And you know what? If you think about it, it actually probably could be both. And another one that it could be is parenteral, because parenteral is through a cut or a puncture or a bite or anything like that that gets through the skin. But thinking about it, it definitely could be probably even, I think, indirect as well. And then lastly, what is the difference between inherited immunity and acquired immunity? All right. Does anybody think they might have an answer for that one? Ms. Mesmer is saying, like the polio vaccine, our generation doesn't need it now, so it is inherited. That definitely is true, absolutely. So, and what I have here for my answer that I went ahead and jotted down, does anybody else have any other answers to go along with what Ms. Mesmer had to say as to what they think is the difference between inherited and acquired? If you think about like the two words, like inherited and then acquired, like there's a big difference between those two words. Like, what does it mean if you inherit something? All right, so inherited, what that means is you're born with it. So the difference between inherited immunity and acquired immunity, because acquired is something that you can get at some later time. Yes, Marissa is saying genetic. So inherited essentially is genetic. You're born with it. And then also acquired immunity is you gain it through a lifetime, through a vaccination or an immunization or something like that. So that's what the difference is between inherited immunity and acquired immunity. One you're born with, one you're not, and you get it through lifetime, through vaccination, or even you contract the disease and your body fights it off, stuff like that. And that is it for my section. So I am going to go ahead and turn off my video and my mic, and I am going to pass it on.
Okay, can everyone hear me?
Yes.
Okay, so my section of the project is disease transmission in the dental office, hand hygiene, and PPE. So these are just the top 5 disease transmissions in the dental office. We'll be going over those individually. Okay, so patient to dental team is microorganisms from the patient's mouth can be passed to the dental team through the following ways: direct contact through patient's blood or saliva, if the dental team member has a cut on the skin around the fingernail area. Also, droplet infection affects the mucosal surfaces of the eyes, nose, and mouth. And then also indirect contact can occur by touching contaminated surfaces or also contaminated instruments as well. Okay, and then also dental team to patient is spread through a member of the dental team to a patient. This is very unlikely to happen if proper procedures are not followed. However, disease transmission can occur. And these are a couple of different measures to prevent dental team to patient transmission. Yes, Ms. Mesmer.
Sorry to interrupt you, but before it leaves my mind, I just wanted to ask the class. The book says that spread of disease from dental team to patient is very unlikely to happen now. But now that y'all have been in your rotations now for what, 2 weeks, do you believe that that statement is true?
No.
Why not? You guys talk. You don't have to name names and that sort of thing, but tell me, talk about what are you seeing and how does it make you feel?
I think Heather's typing, so I'm going to wait.
Can you hear me?
Yeah, I can hear you.
All right. Well, I know for me, there's a lot less PPE being worn, or a lot of the same PPE being worn than what we were, than what we learned and what we do at clinic and everything. So you kind of you see that happening, and it's just amazing how much it varies from office to office. Like how comfortable and complacent, I guess, you can get in what you do and how you clean up or how you set up, or even when you're dealing with the patient, there can be less PPE and all that. So it's just kind of blows your mind a little bit.
Yeah, I noticed that yesterday at my rotation. They kind of looked at me funny when I was wearing a mask, breaking down the room. So. Okay, so I'm going to move on to patient-to-patient. Transmission is spread through contaminated instruments when instruments is used on one patient and they are transferred to another patient with them not being properly cleaned and sterilized. And a couple of measures to help prevent this transmission is obviously sterilizing instruments, surface barriers, and using patient gloves, especially patient treatment gloves. Dental office to the community is spread through organisms that can leave the dental office and enter through the community. An example being impressions being sent out to dental laboratories. So therefore, whenever those are being sent out, make sure that those are properly disinfected. And washing your hands at the end of the day and changing your clothes and also your shoes before leaving the dental office. And then the last one, I believe, is community to dental office to patient is transmitted when microorganisms enter the dental office through the water supply through the dental unit. This is a waterborne organism that can live inside the dental unit water lines and form biofilm, and is transferred. Sorry, Danielle said something. Okay, it's transferred to the patient through handpieces and air water syringes and also the HVE. To prevent biofilm from building up in the water lines, you should flush the water lines at the beginning and end of the day for 2 minutes, and then also 20 to 30 seconds in between patients. Okay, and then we're going to move on to, does anyone have any questions so far for that first section? Okay, I'm going to move on to hand hygiene. Guidelines to hand hygiene is your hands must be washed before putting on gloves and immediately after removing them. Hands must be washed for 2 minutes at the beginning and at the end of the day and 30 seconds in between patients. And this is a really good picture of what areas we miss and don't miss on our hands. It's kind of something similar that we have in our book, and I think this is kind of a cool picture. Also, continuing on with hand hygiene, talks about alcohol-based hand rubs that are available in gel, foam, or rinses. It's the antiseptic hand rubs. Hand rubs should not be used if hands are visibly soiled or contaminated with anything like blood or saliva. And then what's really important is hand care recommendations by keeping your hands healthy. So like using hand lotions during off hours to prevent your hands from cracking, becoming dry, or chapped. Any questions with that section? Okay. And then the last section is PPE, which we know is personal protective equipment. PPE is to use to protect yourself and other vital areas of your body from pathogens from entering your body. OSHA's BVP standard requires employers to provide employees with appropriate PPE materials without charge. And we all know what PPE that we should have. Those are the following ones listed at the bottom. And then these are the steps for putting on PPE, and then removing PPEs. And then a little note at the bottom, patient treatment gloves should always be the first PPE to be removed and should always be the last PPE to be placed on. Okay, and then I have some questions. Okay, so the first question is, how long should dental water lines be flushed in between patients during the workday? That should be pretty simple. Okay, perfect. Okay. Question 2 is, what part of your hands do we frequently miss during hand washing?
You miss the thumbs a lot, like our cuticles, and the palms, I think. The fingertips.
Okay, yeah. Yeah, for my answers, I said thumbs or the fingernails, so that's good. Yeah, perfect. And then the last question is, why is it important to place gloves on last and remove gloves first during the placement and removal of PPE?
You want to place gloves on last so that you're not touching all kinds of different things before you go into the patient's mouth. And you want that to be the first thing you remove so that you're not putting saliva all over everything else.
Yeah, the main concern is not touching your face. So, all right, perfect. Good. Does anyone else have any questions or concerns? If not, I'm going to give it over to Danielle to present her section.
All right. Hi, guys. Can you guys hear me?
Yep.
All right. Okay, so I covered latex allergies, waste, and item classification. There are 3 common types of allergic reactions due to latex, and they are irritant dermatitis. This is a reaction that leaves the hands dry, irritated, and sometimes the skin will crack. Also, there is type 4 allergic reaction. This is the most common latex allergy. It is a delayed contact reaction that affects the immune system and usually takes 48 to 72 hours for the red itchy rash to appear. Type 1 allergic reaction, this is the most severe reaction that can result in death. This type of reaction can affect the immune system in about 2 to 3 minutes after contacting skin or mucous membranes. This medical emergency is also known as anaphylaxis, which is a result of closing airways. There has been no specific cure found for latex allergies. However, someone who knows or suspects they may be allergic should avoid latex at all times. For waste, CDC and OSHA consider saliva and dentistry to be a potential infectious bodily fluid. The 4 types of waste are general, contaminated, hazardous, and infectious or regulated waste. For general are all non-hazardous, non-regulated waste that should be discarded in plastic or metal containers. The contaminated waste, this is waste that has been in contact with either the blood or bodily fluids. This includes barriers and patient napkins. Hazardous waste is a danger to humans and the environment. These include toxic chemicals and materials. The infectious or regulated waste is capable of transmitting infectious disease by blood-soaked materials, pathologic waste, and sharps. The way these items are classified can be done by the handling, storage, and labeling all depend on the type of waste. PPE should always be worn when dealing with usually all of these wastes. So for general waste, this includes paper towels, paper mixing pads, and any empty food containers. Contaminated waste includes anything that came in contact with either the blood or saliva, such as used barriers, patient napkins, HVE, and saliva ejectors. The other wastes are hazardous waste. These include scrap amalgam, fixer solution, and lead foil found in film X-ray packets. And the infection waste include blood-soaked saliva gauze, wet or dry, and then the pathologic waste includes soft tissues and extracted teeth. Lastly, sharps that include used needles and matrix bands. Do you guys have any questions for me before I go on? All right. So what is the most severe latex allergy? Yes, that is correct. What waste category does lead foil and fixer solution fall under? Yes. Okay, and lastly, what two groups consider saliva and dentistry to be a potential infectious bodily fluid?
Brittany, don't answer.
All right, yes, that's correct. All right, so does anyone have any questions for me? All right. Okay, so this concludes our PowerPoint, and this is the sources that we used.
Good job, you guys. You all did really good.
Woo!
Thank you.
Excellent job,
Thank you.
guys. Doesn't it suck when nobody talks back to you? Give me a green check if you know my feeling now.
Yeah, I do.
Good. Hey, try talking again, Taylor, while I leave my mic on.
Yeah.
I just heard her, so.
I see people talking, but then I can't hear you. I'm just trying to play with my stupid mic button.
Hello.
Okay. All right. Does the group have anything else that they want to share before I take over again?
I don't think so. I think we're good. Are we, girls?
Yep.
Okay, well, first two groups, wonderful jobs. And again, you know, I know that it was like, why is she making us do this? We've already taken that stupid exam and blah, blah, blah. Don't worry about talking too fast, Danielle. I know exactly what you mean. When it's you're the only person talking, you have a tendency to speed it up because the silence makes you nervous. I get it. Okay, just a couple of announcements before we wrap it up. Okay, so discussion board, very good. The one for ortho is going to come alive tomorrow. Okay, so I'm glad to see that you guys did such a good job on your discussion boards. I posted a comment. Sorry, I'm trying to read texts and talk at the same time. Workbooks, Friday group will be due tomorrow. Wednesday group will be due next Wednesday. And it's just because of the way those stupid weeks run with us going Friday to Thursday is how the weeks work. So please bring in your workbooks to me. I'm going to be looking for the two chapters, the chapter on peds and the chapters on ortho. Those are the only two chapters I'm grading because the other two chapters should have been a part of like DNA 110, DNA 113, okay? And then I just want to clarify, I made an announcement on this. The schedule originally said that we weren't going to be treating patients on Friday, July 11th, but we will be. We have to do that so that way we get equal number of patient hours in and that sort of thing. So those are just my few announcements. The test will be available for, I think it's tomorrow to, yeah, it's the 12th through the 17th. So you have 5 days to take it. The test has to be done at either the Locust Grove or the Fredericksburg Campus Testing Center because they require us to do it with distance education to have proctored exams. Oh, Saturday through Thursday. Okay, thanks, Taylor, for clarifying that. So let me know if we have any issues. Hold on a sec, guys, before I have my test cover sheet, and I want to make sure that I didn't put a different date. Hang on. Okay, So 6/14 to 6/19 is the dates that I put on the test cover sheet. Is that what you had? Yes. Okay, I did get it right. Yay. Okay, so the 14th through the 19th is when the test is available. It's going to cover the chapters that were on the syllabus. I believe it is about 50 questions between peds and ortho. So you should be good to go. You'll have your discussion board due. I'll double check the quizzes. Sarah says, what about the articles? Yes, read over the articles. You may not see the articles right away, but they will be popping up throughout the course. So do take a peek at those so that way it'll help you. So anything else, any questions, concerns, discussion that you guys want to have? Taylor says, do we just read them? No assignments with the articles. Yeah, just read them. You can use them in your discussion board to, you know how the discussion board says to quote other sources and that sort of thing. So you can use them in that manner. My thought process was maybe to use them as some extra credit on the final exam if we need it, that sort of thing. So that's why they're out there. Sometimes it's just good to hear things in a different way. Any other questions or concerns before we log off? We rocked it, guys. Next week we'll start into oral surgery, so take a peek at those videos. How much time do we have for the questions? I like the questions. I don't think it's not a timed exam, so take your time, read them. I've got it where you can backtrack and that sort of thing. So. Y'all are funny. Yeah, because I make the quizzes timed just because you're in an unproctored environment. But and remember, the testing center has some, I don't know that it's completely shortened, but yeah, I think they close like at 2 on Fridays and stuff like that. So make sure you check the website for their hours. I hate for you to drive to campus and then they say you can't take it or whatever, or it's closed. Okay, sweet ladies, I will see some of you tomorrow, others of you next Wednesday. Email me, text me if you have any questions or concerns, and I'll try to get to you as quick as I can. Good night.
Good night.
You're waiting.